to those that have registered and those that are attending. If you have any objection to the recording, please let me know. I'll give you a few seconds. Okay, great, thank you. So today, I would like to start off by introducing myself. My name is Pragashni Murugan. I am the program officer working closely with Nadia Rafif, who's the advocacy and influence lead at ITPC. Nadia does send her apologies as she's busy attending a summit on intellectual property. So she sends all of her luck for today's presentation. And yeah, so to start off with, I would like to let you know that there is interpretation in French. So if you go to the interpretation globe at the bottom of your screen, then you can select the French language that you will need to listen to. Okay, so for today's agenda, before I go into the agenda, I would like to also introduce you to Bactrin Kilongo, who's the technical advisor at ITPC, who will be the moderator for the session. We are also fortunate to have presentations by Ange Mavula from the Democratic Republic of Congo, as well as Lawrence Kanyongwa from Malawi, and Dio Mtobuka from Rwanda. These three important members do form part of our community advocacy network, who we have been collaborating with since 2019, focusing mainly on monitoring community engagement as well as the levels of community engagement. We will also hear from our close partner slash funder, Maureen Sowayo from ICAP at Columbia University, who will provide reflections on the work of by the Community Advocacy Network on behalf of the CEQA network. So the Community Advocacy Network members, these pictures basically capture the 22 countries that have been involved in the CEQA meetings, as well as these webinars over the past 2 or 3 years. As an overview on the community engagement advocacy project, initially in 2022 and between 2022 and 2023, there were an identification of country-specific gaps that this project sought to implement, which was based on the rollout of the 2022 and 2023 implementation of the community engagement monitoring tool that focused on also monitoring the levels of engagement within the DSD policy, program, and community levels. From here, from these important results, the Community Advocacy Network thereafter developed and submitted 2 or 3 priority gaps and challenges that focused on translating the data that was collected within this time period into advocacy initiatives. The project was funded by the Bill and Melinda Gates Foundation, and it was rolled out in 20 countries by 25 CAN network members between June to November 2024. Thereafter, ITPC was involved with the consolidation of the country reports into a final country report that highlighted or assessed the advocacy outcomes per country. The main objectives of the community engagement advocacy project was to strengthen community engagement by using data to inform advocacy through developing, promoting, and supporting the use of the community engagement tracking tool among the CAN members, but most importantly, to support the CAN members to use data to drive change and to strategically inform program changes. We anticipated that the advocacy areas of focus were the inclusion of communities in decision-making tables and processes and community engagement or CLM structure committees. We anticipated the higher involvement of DSD program implementation, the implementation of recipients of care within feedback systems in DSD, for example, scorecards, increase funding at a national level for DSD programs, and to strengthen, most importantly, the community response and to amplify the visibility as well as voices of communities. The overall impact at a glance is that we found that the inclusion of community data has positively driven advocacy initiatives. There has been measurable impact for change and sustainable health systems. It has identified potential leverage points for financially sustainable community engagement advocacy efforts. Most importantly, this process that the CAN members have been extensively involved in has underscored the transformative potential of community-driven approaches in shaping health policies and programs. It has also laid the groundwork for more inclusive and responsive health service delivery models. If we look at the impact, look at the impact per region, meaning across the Eastern Africa, across Southern Africa, as well as across Western and Central Africa. Overall, countries have achieved short-term advocacy successes, which has informed long-term advocacy plans. Due to the time frame, the community advocacy network had limited time to implement this project. Therefore, the idea from the community advocacy network was to develop short-term advocacy plans, but use the outcomes of these short-term advocacy plans to inform the development of long-term advocacy plans. All countries have identified how to sustain the positive outcomes from the community advocacy project, which are mainly around continued engagement, feedback, and advocacy with all stakeholders, capacity building of communities, and the institutionalization of community engagement related activities. The impact of across countries. Malawi, Rwanda, and DRC will do a deep dive on the impact of community engagement on the advocacy process. We, in addition to the development of a report on the results from the implementation by the 25 CAN members, also developed 3 case studies that were generated from the data collected and the advocacy initiatives from Malawi, Rwanda, and DRC, which the team will, or our colleagues will present on after my presentation. So in addition to the case studies by Malawi, Rwanda, and DRC, we also would like to bring you attention to other examples from Nigeria, Uganda, Burundi, as well as from Kenya. This is not, this was selected as random, and we have many more case studies within or many more examples on the achievement of the advocacy implementation by the other CAN members which we will share in the report at the end of this presentation. So for Nigeria, communities identify the lack of linkages between the community pharmacies as well as recipients of care as a key gap which helps shape the national DSD strategy. In Uganda, district level advocacy led to the appointment of a DSD focal person in Matiani district, a position that did not exist before. Similarly, Burundi reported that community representatives were directly involved in the finalization of a national guidance on the role that communities can play in the health system. Within Kenya, I've added two examples from our community advocacy network advisory group, which is Ishtar, which is made up of or an organization that focuses on MSMs, men who have sex with men. They advocated for the inclusive of DSD guidelines and training for service providers. And the Sex Workers Alliance from Kenya partnered with stakeholders to improve the access to services and build rights awareness. So some of the challenges that were reported by our partners was, as mentioned before, the short time frame for implementation, as well as short-term funding cycles affects the scalability, as well as the sustainability of community engagement advocacy efforts. Community-generated data is still misunderstood and often not used. There's also a lack of awareness on DSD, as some of the healthcare workers, as well as the recipients of care, or mainly the recipients of care, did mention that although they receive DSD, HIV differentiated service delivery, they were not sure about the correct definitions of DSD. And as we all know, that we are severely impacted by the stop order or the US freeze or the administration that was passed on the 25th of January that has further led to funding crisis, and this has decentralized some of the existing CLM efforts as there has been an immediate stop to CLM activities. So the key messages from ITPC, as well as working very closely with the community advocacy network, is that CLM now more than ever should be used to leverage and improve HIV programs. We should consolidate existing evidence to ensure community data remains relevant. It is a critical time now more than ever to sustain community engagement, as well as CLM efforts. Advocacy initiatives and policy should be geared towards emergency responses and the changing and the variability in geopolitical contexts. The questions that we should be focusing on is how do we as communities transform crisis into opportunities? We also need to rethink the funding and costing models, as well as involving communities to ensure sustainability of efforts at the current situation. As an advantage, communities do have an advantage with CLM, as communities are able to monitor HIV programs in resource-constrained settings. It is important that communities show their visibility even during any governmental or any stakeholder meetings regarding the responses to the US freeze. Community engagement will also need to be reprogrammed in response to a new or in response to the HIV response due to the funding crisis. I will also add the resource page within the ITPC website, which we have dedicated to the work on community engagement. And these are some of the resources that we have published so far in close collaboration with the CAN members as well as ICAP at Columbia University. With that, I would like to thank all members of the Community Advocacy Network as well as the representatives who have joined us today from ICAP at Columbia University or the Sequent Network. Thank you.
Thank you very much, Pragashini. So that's a snapshot of the work that's been going on for 2 years. Just to remind folks who've joined, the topic of this webinar is how data drives advocacy, and essentially get into the space of looking at sustaining community engagement and response in DSD programs. The next session will give some case studies of some of the work that has gone on in across the regions, also as a snapshot. It's important to note that the work is essentially demonstrating that communities have identified problems around access to quality services and have then gone on to document using data what those issues are, after which they then get to put together a plan on how to, as communities, contribute to ensuring there's change and or strengthening the existing interventions. And so you look at the trajectory of where the advocacy work then gets to be developed and then document the impact that advocacy work has had in ensuring that the community engagement efforts actually do improve healthcare service provision in the field of HIV. So we will have 3 case study presentations. I will start with Dio, Dr. Dio from Rwanda, who will come on stage and share with us, starting with the subtitle of the main theme, which is unique to their work. And then that will be followed by, he'll be followed by Lawrence from Malawi, who will also follow the same format. And then last but not least, we will give Ange, who was a bit committed in another call, needed some time to put his thoughts together, who will be the third presenter. And then I'll open up the session for folks in the room who would like to quickly share their experiences from other countries, after which we will have comments and questions from other webinar attendees. So without much further ado, Dio, over to you, hoping that the presentation is, yeah. Thank you.
Thank you, Bhakti. Thank you, colleagues. I think everyone is seeing the screen. Yeah, it's my pleasure to share the experience of the achievement in terms of integration of communities in health facilities, and what we have been doing in terms of training and improving monitoring of DSD on the improved DSD quality services.
So Dio,
Case of Rwanda.
Could you increase your volume a bit so that the interpreters are able to hear you?
Yes, I don't know if they can hear my voice well.
Now that's better. Go ahead.
Let me get closer to the computer. Thank you very much. It is a pleasure for a network of people living with HIV in Rwanda to share how data drives advocacy and sustainability community engagement and the response in terms of DSD programs. As you have highlighted in terms of the achievement that Rwanda has as a network, what we have achieved through the activities that we have done, I would like to ask the progression to go to the next slide. Yes, as you can see, this is aiming to aim and define the objective of the advocacy work that we did, advocacy activities that we were undertaking, and the result we'll be sharing with you. Then, and the overall reflection and the key takeaways in terms of what we implemented through this coordination of DSD activities in Rwanda. Next, please. The major objective of advocacy work was to improve the meaningful engagement of PRHIV in DSD, especially in terms of policy development, program design, planning, and implementation vis-a-vis M&E. Then the second was to sustain strong and meaningful engagement for the communities. And the third one was to identify the potential opportunities for leveraging the community engagement gains to justify the addition for continued advocacy and community engagement efforts. In other words, is to show that with the community advocacy, with the community improved data, with the community engagement in terms of policies, in terms of implementing, that we can do, then we see it as much important as we are going to highlight to the next slide. Next, please. Of course, in training by as a community that as a network of people living with HIV through the support of ITPC on community engagement, we conducted a community engagement assessment in 2023, and community engagement advocacy focusing on reported gaps related the priorities that the first priority was to improve active participation of recipient of care in supportive supervision, which was above 33%. Second priority was to improve the percentage of health facilities offering DSD services, where community scorecard and recipient of care satisfaction survey was above 33. Next, please. Yes, as you can see in the assessment that we did 2022, 2023, on policy levels, we had 6 indicators. Among of 6 indicators, you allow me not to go each indicator because there are one indicator which is a biggest gap that is not, or are not done, like DSD technical working group was not really engaged, where the community members could participate in technical working group. This is something that we think as a community members to be part of technical work group, to share their practices, their needs, their gaps, their challenges would be something that is of importance, which was, as the case of Rwanda, by this was not implemented. And when we look at the programmatic level, everything was done except indicator number 5. When you look at the score, it shows that there is still a gap that needs to be filled, which is this supportive supervision visits that includes only 33% out of 100%. It is something that we think needs to be really engaged and increase the community participatory in terms of supervision at the service at the service centers, health service centers. Then out on the indicator community level, again, the last two indicators, they were partially did, and we achieved 75% of recipient of care and community members who attended health education learning sessions. But that 25% that is remaining, it is still a gap for us. And when you look at the 33 of health facilities offering DSD services where community scorecard and recipient of care satisfaction survey are implemented. When you look at the numbers of health facilities that are engaged in this, you see it still a big gap. Then you would imagine 67%. What is happening there, and what should we do to make sure that they are as well a match in practice as the same as 33%. Next. As the community engagement advocacy, which was convened and on October 2024, you would see it's was a session that was really engaged with the partners, with the government, with the community itself. You can see how really a tremendous one in terms of success, as I would say. And this is an evidence that when the community gather with the stakeholders, decision can be taken and recommended into the practical aspect. Next. The result, when we look at the policy as I indicated, Rwanda achieved a high score in 2022, reflecting on strong government commitment, community inclusion in DSD framework, for which, of course, there are identified gaps in peer education training, whereby IRP Plus identified the deficiencies in regular training for peer educators and DSD model, leading to the diminished community engagement, which means this training in terms of coverage and reach, we saw it as a gap, and it's something that we think, building on that, on what has been done, it could improve the programmatic and improve the performance of services or at the health level, health facility level. Then, as you look at community-led advocacy that was enhanced training in response of identified gap, extensive community sensitization, resulting in the communities advocating for comprehensive training. Consequently, all DSD health facilities, sorry, someone is, okay, it's the internet interruption. I'm very sorry. We conducted the extensive community sensitization, resulting in the communities advocating for comprehensive training. Consequently, all DSD health facility training incorporated recipient of care in 2023. As I saw that we had reached 33%, those health facilities where the communities that around that are service users at the health facilities are 33%, were really engaged in this in the DSD training. Next. Then as the outcome, the expansion of community monitoring tool, despite the progress, assessment indicated raw implementation of community scorecard and recipient of care satisfaction survey in DSD health facilities. Building on these findings, the advocacy campaign emphasizing the principle of nothing for us without us, targeting the key stakeholders. This initiative led to peer educators monitoring services, quality of service in 109 health facilities, increasing coverage from 33% 23 to 53% in 2024. Again, which is still the gap that there are that increment, but still for us, we see it when you look at the 47% remaining in gaining, that would be an added advantage for us in health response and engagement. Then strategic use of data-driven. As a strategic application, data-driven advocacy and collaboration with diverse partners effectively addressed community engagement gaps in monitoring and evaluation, sustaining the progress at the policy level and implementation level. Then when we come at the prioritization of community-led monitoring, as a network of people living with HIV, we have prioritized advocacy to expand community-led monitoring across all DSD healthcare centers nationwide, reinforcing the integration of community perspective in health delivery. Though that is what we think with community-led monitoring, CRM would be a better opportunity to be scaled up at all health facilities to really make use of DSD approach and can improve the healthcare service delivery in lead to a better life. Next. Overall reflection, I would say that Rwanda experience, we demonstrated that a meaningful community engagement in differentiated service delivery is achievable when backed by political will, structured advocacy, and community-led actions. Integrating recipient of care or service users in training and monitoring activities is not only the best practice, but we see it necessary strategy to improve service quality and accountability in HIV response and other related health challenges. Sustained gaps in monitoring tools, as we are aware that the monitoring tool is the key to really have a number that will help us to advocate with evidence. Then the survey underscore the need to institutionalize community-led monitoring across all service delivery points. That, as we are looking at the integration, that would be a better tool to really see and capture the meaningful of community engagement. Strategic partnership between civil society, government, and the donor creates powerful enabling environment to operationalize the principle. Nothing for us without us. And we think that this partnership would be hyping up as a wake-up call for each of us in the circle to make sure that every recipient of care, service users, if you want, a service users is centered and contributing towards what is best for us. Next. Maybe it's yes. Communities are not just beneficiaries, they are expert implementers in HIV response. As I was saying, nothing for us without us. You know, we've been in this for some good time. We've been in prevention. We've been in treatment and in treatment services. We've been on treatment services. We've been mental health attacks us and reflect, fight it back and make sure that we can live without stigma. And we believe as service users, we are the expert. We don't need any more expert. Let's start with us, then we can change the narrative. Training and capacitating peer educators is the foundation to improve DSD outcome. We believe as our colleagues, sisters and brothers, mothers and fathers on the ground at the grassroots, they're the ones best to really measure the DSD outcome, improve DSD outcomes if they are ready, if they are really capacitated. Systematic inclusion of the recipient of care in monitoring and evaluation drives or leads to the accountability and quality improvement. At least every service user should be able to know the rights, his or her rights, and can be able to question and recommend. Evidence-based advocacy can catalyze structural changes and expand community-led practices. Obviously, with the data-driven decisions will even help us to advocate for more, as we are seeing financial donors. The donor priorities are only focused on their priorities. Then, as we have the evidence as communities, will lead us to even show that the service users' priorities should be directing the donor direction than us following the donor directions. Next. Institutionalize regular training as recommendations for peer providers. Ensure that all peer providers are routinely trained. Obviously, when we talk about routinely, we don't mean that day to day, but at least every quarter, every once a year, they should be trained, they should be engaged, they should be part of the process. Scale up a community-led monitoring. We believe that implementation of community scorecard and satisfaction survey to reach 100% at the facilities by this year. That's what we thought, but now things has. Then formalize the role of communities in M&E framework. Embed service users or recipient of care and community actors into national monitoring and supervision structure for DSD services. This is more important. Strengthen feedback loops between facilities and communities. Of course, we need to work hand in hand, support each other, scratch each one back each other, than this developing this what I would call that conflicting between service users and at the facilities and the health deliverer. And we think if we get as service users at the feedback level would be something for each of us, not only to the health facilities, but as well to the impact on treatment and service delivery will be improved. Invest in sustainable partnership, long-term collaboration between the civil society and donor institutionalized to the community engagement in the national HIV response strategies would be a great achievement. Localizing of funding, because coping with the current issue cuts of aid, civil society needs to be empowered to take the lead in HIV response, which will even be an advantage in sustainability approach. Next. Murakoze cyane. Thank you. Over.
Thank you very much, Dio, for your detailed, extensive presentation from your country, Rwanda. I think I've said this time without number that if you don't have data and document it, if you don't share what you've documented, then it doesn't exist. And if it therefore doesn't exist in perception, then there is no way your work is going to be supported. So data, documenting, sharing, such as what we are doing today in this webinar and in other fora, will help contribute in the sustainability agenda and the strengthening of the various systems that we are making sure we would like to see continue being improved, strengthened, and supported. So thank you very much. Next up, Lawrence from Malawi. The floor is yours.
Thank you very much, Backtree, for welcoming me to present. Welcome to Malawi, the land of the lake, the land of the mountain, and the land of the big five. So that's what we are known for as the warm heart of Africa. My presentation will My presentation title is How Data
Lawrence,
Drives Advocacy.
sorry, Lawrence, you seem to be cutting off.
Okay. Can you hear me now?
Yes, yes, I can.
All right. Yes, I was saying my presentation title is How Data Drives Advocacy, Sustaining Community Engagement and Response in DSD Programs, Valuing the Role of Community in Improving DSD Implementation. I'm representing the Malawi network of people living with HIV and AIDS. Next. The next slide. Yes. The aims, the study outline, the outline of the presentation is the same as Dale's. So we can go to the next slide. Yes. In 2022, we carried out a community engagement assessment, which revealed that communities were generally minimally involved or not involved at all in DSD design, implementation, and monitoring. If you are familiar with the community engagement framework, there are a number of domains that we assess. Of those domains, the design part, the implementation, and the monitoring were the ones that we discovered that communities were not engaged or they were minimally engaged. We had small percentages. And then the community engagement scores were especially low at the program level. So the Manage Plus, the network spearheaded efforts to improve community engagement, engaging consistently with representatives of the Ministry of Health at central level as well as at district level. Next. So we carried out the assessment. It showed a low number of health facilities with DSD models where recipients of care and community members work as service providers. So you know that in health centers, we have government or the employed workers, health workers, but we also have community members that also do work as service providers, doing all sorts of very important activities in terms of task shifting at health center level. So in 2024, our aim was to influence district health facilities to increase the number of recipients of care that are supporting DSD implementation at health center level. We sought to understand the level of community engagement at implementation level and influence health centers to recognize the role played by community members. So as you know that communities are playing a very significant role in health centers, doing work, most of which they are not even paid for, but they do the work because they have a passion to do that. So what we want is to see how that can be recognized and how, as Rwanda said, that can also be institutionalized. Next. So what we did in terms of the activities was to do a mapping of community cadres that provide different services. And we found out that there were these cadres: treatment supporters, expert clients, community care groups, community adolescent treatment supporters. These are called CATs, very clever as a cat. Recipient of care support groups. These support groups are in the communities, but they also work very much closely with the health centers. We also have sputum collection point volunteers. These are volunteers that do work on TB. They collect samples from people that they suspect to be infected with TB. They collect the samples and then take them to the health centers for testing. So there are even more than these categories of community cadres that are working alongside the health facilities. So after the mapping, we also did other activities which involved radio interviews by community members, community dialogue sessions. These are sessions where we discuss issues at community level. We also did lobbying with decision makers at district level, presentations to the district health management teams, lobbying at national level, various sessions, the Global Fund, national dialogues, as well as the Global Fund concept note development process, the PEPFAR development process. We participated in all those programs and activities as part of this community engagement process. Next. So just to explain in terms of the mapping, through community dialogue sessions and partnerships with health management teams, the roles of various community cadres was clarified and better valued. So we saw that there is value in the community cadres. We are aware that previously, I think in 2021, the PEPFAR conducted a study to look at the community cadres and their roles. But what we were doing here was to involve the community to identify their own roles, which was even more valuable. So this led to more understanding and to a more meaningful engagement of communities at health center level. Next. So some of the common tasks that community cadres do include pre-test counseling, post-test counseling, treatment adherence counseling, default tracing, bringing defaulters back to care, sputum collection, as I already said, provision of health talks at outpatient patient departments of the health facilities, early infant diagnosis programs, as well as nutrition education. So they are doing all these tasks without pay. These are just volunteers. Next. We also did sensitization. My colleague also, I think it was Pragashini who indicated that one of the issues that was noted in the community engagement process was the low knowledge of DSD by recipients of care as well as even service providers. So we worked on sensitizing recipients of care to raise their awareness on DSD and the importance of community engagement. Recipients of care also participated in the following: technical working group and thematic working groups meetings, policy validation exercises, DSD program design meetings, as well as planning meetings to prioritize DSD models. These particular activities were done at the national level as well as district level. So based on what we found, this was one of the advocacy issues to say we have discovered low involvement in the design. We therefore have to ensure that recipients of care are attending technical working group meetings so that during the next scoring, we would have at least 100% on these indicators. Next. In terms of outcomes of our work, we found out that community engagement increased from 35% in 2022 to 57% in 2023, especially at the level of designing of DSD policies and programs. So we would ensure that when designing is done, the high-level meetings of the Ministry of Health, we are there. This will continue. Sensitization of recipients of care to community engagement empowered them to be more actively vocal. So, for instance, when the government decided to ration cotrimoxazole prevention therapy in hospitals, recipients of care representatives at national level and even at district level strongly advocated against this, which resulted in the government reversing the decision and being encouraged to address its supply chain issues. So we had recipients of care talking on national radios against this decision, and recipients of care also presented a petition to the National Assembly, which was received by Minister of Health, and that issue also was debated by the Parliamentary Committee on Health. So this was reversed. So we had this drug being dispensed as usual, because the drug comes in as part of the Global Fund package, but I think we saw that the government made a U-turn on this. In addition, Manage Plus advocated for more financial support for community-led monitoring, and we managed to secure COVID-19 response mechanism Global Fund funding to implement further CLM activities. So in the GC7, which is currently at implementation phase, we have a strong component on community systems strengthening and community-led monitoring due to our advocacy. because we used our evidence from the CE assessment. As well as the C19 RM, we also have a strong component of CLM and community engagement. Next. Our reflections are that meaningful engagement of community cadres is key in ensuring sustainability. Meaningful engagement of communities in all stages, including during implementation, ensures community satisfaction. What we are saying is that the future is community-led. We have to engage communities in all stages of DSD. I'm just coming out from a meeting where we were discussing, led by National AIDS Commission and Ministry of Health, where we were discussing prevention efforts and how they have been affected by the stop work order. So coming out from the CE assessment, I also put up a point which has been adopted that we really have to develop guidelines on how the ministry is going to engage communities, and that has been taken on board. It is coming from this assessment. Next. The next is to thank you all for giving me time. Thank you, and over to the moderator.
Thank you very much, Lawrence. That was very insightful as well. It's interesting to get to hear some of these things that are real, that literally did, happen from an influencing point of view to bring about various changes in real time. Many a time we never get to have opportunities to just speak up and influence various changes when things are going wrong. So thank you very much, Lawrence. People who want to type their questions and comments, please do so on the chat. I can see Maureen has two, so we'll give her the opportunities to ask. Welcome to other comrades who've landed. So I would like to go move from Malawi to DRC and ask Ange to come, because I can see you have been able to join. Ange, bonjour. You're there?
Bonjour, 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 Maxime. Bonjour tout le monde.
Bonjour.
Est-ce que vous me voyez, je crois?
Yes. And the presentation.
Ok. Je m'appelle Ange Mavoula. Je suis le chargé ou le responsable de l'Union congolaise des organisations des personnes vivant avec le VIH. Et comme le disait Pragashner, je suis dans le système depuis 2019. On a commencé le travail
Okay.
d'engagement communautaire.
Just
Voilà.
1 second, Ange. So, Pragashne, I can hear two English interpreters.
Yes, I'm not
And
sure what's going on.
they're speaking over each other. So
Yeah.
I can't actually hear.
Interpreters, can you speak? I'm not sure why you're speaking over each other.
No,
Can you
there are two English
Yeah,
folks
but they're supposed to
speaking
alternate.
at the same time.
Yeah. So Jean and John, can you hear me? Okay, please can one of you speak? Okay, can Jean close his mic, please? Okay, sorry about that, Ange. You can go ahead.
Go ahead, Ange.
Ok, je disais que je suis Ange Mavola, le responsable du réseau des organisations des personnes vivant avec le VIH de la République démocratique du Congo. Là, je vais devoir présenter le cas de la République démocratique du Congo sur l'engagement communautaire. Slide. Ça, c'est le plan de la présentation. Nous avons le but et les objectifs de l'engagement. Après, nous allons dérouler les activités que nous avons entreprises pendant la période avant d'arriver aux résultats de l'engagement et nous terminerons par une réflexion ou des réflexions générales et des messages clés. Slide. Comme objectif, il est plutôt de renforcer la voix des communautés dans les politiques de santé et la conception des programmes DSD. Parce que nous avons remarqué que les communautés ne sont pas très souvent impliquées ou pas complètement ou totalement impliquées. C'est pourquoi nous nous sommes lancés dans cette dynamique avec comme objectif spécifique assurer la participation significative et la visibilité des réseaux nationaux de personnes vivant avec le VIH et leurs défenseurs dans l'élaboration des politiques DSD et des supports de communication. Deuxième objectif, il est question de pouvoir veiller à ce que les bénéficiaires de soins ou les membres des communautés participent dans ou soient physiquement présents à la conception des modèles euh, de délivration des services différenciés au niveau des programmes. Et enfin, que les bénéficiaires de soins ou membres des communautés devraient bénéficier des séances d'apprentissage continu en matière d'éducation à la santé. Ce sont là les trois objectifs. Et en termes d'activité, slide, nous avons eu trois activités. La première, c'était des réunions avec le coordonnateur pays DSD pour assurer l'implication des bénéficiaires de soins dans l'élaboration des documents d'intégration des maladies non transmissibles. En fait, le pays était en train d'élaborer des documents d'intégration des maladies non transmissibles et par rapport à cela, nous avons assuré justement la participation significative des bénéficiaires. Comme deuxième activité, nous avons tenu des réunions préalables avec les bénéficiaires des soins pour préparer justement leur contributions ou leurs propositions par rapport aux documents qui seront réalisés. Et nous avons eu aussi des réunions de sensibilisation en virtuel avec des organisations de bénéficiaires dans d'autres provinces parce qu'en fait, tout le travail était focalisé à Kinshasa, qui est la capitale, sachant bien que Kinshasa seul ne représente pas la République démocratique du Congo. Slide. La quatrième activité, il était question d'organiser des séances de travail avec les bénéficiaires pour assurer et garantir leur implication en termes de sensibilisation, bien évidemment. L'autre activité, c'était de sensibiliser les prestataires de soins dans 5 structures de santé que nous avons ciblées. Ce sont des structures à haut impact, donc à haut volume, avec beaucoup de patients. pour justement assurer des séances d'apprentissage continu en matière d'éducation à la santé en faveur de plus de bénéficiaires. Nous avons aussi sensibilisé les bénéficiaires des soins sur l'importance de participer aux séances d'éducation à la santé. Tout ça, c'est partant de l'évaluation que nous avons faite avant et des gaps que nous avons constatés. C'est pourquoi nous avons adressé des activités en guise de réponse aux faiblesses que nous avons constatées. Et la dernière activité, c'était d'assurer le suivi de la participation des bénéficiaires aux séances. Et par rapport à ça, nous avons eu comme résultat, d'abord, nous avons pu arracher à ce que dans où le dépistage ou la délégation des tâches de dépistage aux communautaires soit intégrée dans le guide pratique d'offre des services de dépistage du VIH au pays. C'est-à-dire que désormais, les communautaires sont ou ont la tâche de pouvoir exercer ou faire le dépistage tel que normé dans les documents ou des politiques nationales. Ce qui n'était pas le cas avant, parce que c'est vrai, ça se faisait de façon isolée, mais pas très normée et pas aussi acceptée. Mais au moins, désormais, c'est officiel et c'est accepté par les programmes et les politiques du pays. En dehors de ça, il y a aussi un énorme travail que les communautaires ont fait à pouvoir intégrer la maladie du VIH au stade avancé dans le guide de prise en charge euh, à l'infection à VIH. Pour dire que par rapport à ça, pas plus qu'hier, hein, ça c'est une parenthèse, nous sommes dans le processus de la revue des programmes Fonds mondial avec toute la suspension des financements ou des gels des financements américains. Et on est revenu encore dans la priorisation que nous allons faire, que le VIH au stade avancé soit pris en priorité dans les activités à programmer. Ça aussi, c'est une réussite que nous devons souligner en passant. Et nous avons aussi sensibilisé 10 prestataires de soins. Là-dedans, il y a les infirmiers titulaires et les responsables de l'accompagnement psychosocial. Nous avons donc sensibilisé sur la programmation des séances d'apprentissage continu en matière d'éducation à la santé. Et dans la même lancée, 51 bénéficiaires de soins ont été sensibilisés sur l'importance de participer aux séances d'apprentissage en matière d'éducation à la santé. Comme réflexion et deux messages clés, on n'a pas voulu aller dans beaucoup de messages, mais au moins, nous adressons au gouvernement pour leur dire que les décès dus à la maladie au VIH à un stade avancé sont évitables. Seulement avec une petite volonté politique et on peut éviter tous ces décès. Et à la communauté, nous leur demandons, nous nous demandons de ne pas attendre que nous soyons invités sur la table des négociations, mais plutôt nous devons nous faire inviter. Nous devons être présents partout où les discussions portent sur notre prise en charge, sur notre intérêt, parce que c'est une question de survie et notre survie en dépend. Voilà, ainsi dit, en quelques slides et respectant le temps qui m'avait été réparti, ma contribution sur l'engagement communautaire en République démocratique du Congo. Je vous remercie.
Okay, so maybe I'll give you 1 minute, Ange, to summarize your key messages. There were 2 more slides there.
Ouais, nos messages clés, c'est qu'ils sont adressés vraiment au gouvernement. Nous nous sommes rendus compte que en 20e siècle, en plein 21e siècle, il n'y a aucune raison pour que les personnes meurent du sida ou meurent encore du sida. En plein 21e siècle, le gouvernement doit mettre des moyens et doit présenter cette volonté politique pour pouvoir mettre les moyens justement pour lutter contre le VIH et en priorité le VIH ou la maladie du VIH au stade avancé. Et par rapport à la communauté, c'est de ne pas croiser les bras, de ne pas attendre qu'on soit invité. Il faut nous faire inviter sur toutes les tables de négociation pour apporter notre petite pierre à l'édifice. Voilà les grands messages que je peux adresser. Merci.
Awesome. Thank you very much, Ange. Much appreciated. So in the next 10 or so minutes, we're going to do three things. One, I'm going to invite Maureen to ask some two pertinent questions briefly and precisely to at least two panelists that you put on the chat. Actually, now three questions. Okay. Very quickly, very briefly, so that the panelists can respond one after another. And then the next part, before Maureen, you close for us, or you give a sequence reflections, is I am going to ask two people from the audience randomly, Elsie and Otuoma Nelson, about data,
Naza na
importance
conference
of data, sustaining data
na biro bena
processes,
na conference en ligne.
and how that gets to be affected under the current funding crisis. So prepare, Elsie and Nelson. Over to you, Maureen. Your
Thank
questions.
you, yes,
your three questions.
Absolutely. And a pleasure to be here with all of you and to listen to these reflections. They're quite insightful. My three very quick questions, and thank
First,
you to
tell
Rwanda.
us who you are. Let's not assume.
Oh, yes. Absolutely. My name is Maureen Siowai. I'm the interim project director for the Sequin Impact Network. This is a network that's convened by ICAP at Columbia University, and of course, with a lot of collaboration with ITPC, and really glad to be here and talking to the Community Advocacy Network here. Excellent submissions today from Rwanda, from Malawi, and from DRC. I have three quick questions for each of you, starting with Dio. And Dio, excellent work in Rwanda. And it seems like from your submissions and from other anecdotal information that I have, it looks like Rwanda is still going ahead and prioritizing the community agenda, and particularly from your talk today, spearing ahead with the community scorecard agenda, the recipient of care satisfaction surveys in Rwanda, to try and improve them from where they were at. They were initially at 33%, now at 53%, and now you're looking at beyond that. And that remains a priority in Rwanda. So commendable work with the community engagement piece and the scores that you even showed there on your slide. So how are these initiatives being sustained, given the current challenges in funding many countries are experiencing? I'm curious to know how these community initiatives are being sustained in Rwanda. And then a quick question for Lawrence is around we recognize that a lot of countries are now rapidly, and unfortunately in some instances in an unstructured way, moving towards integrating HIV service or HIV service delivery into the standard or to the mainstream healthcare platforms that they have in country at the different levels, from tertiary to primary to community levels. And I'm wondering, how is Manet Plus looking at engaging with the Ministry of Health to make sure that this work that you're doing under the community engagement to map out the community cadres and use them efficiently, that continues to be an area of interest and an area of aggressive, more so now than ever, use as services are being integrated into routine healthcare settings, so that we don't lose the quality of care that recipients of care becoming accustomed to. And then for Ange Mavula, just finding out to what extent are you working with the network within your country to be engaged with the emergency response, and right now begin to drive the agenda that, yeah, as Dio said, nothing for us without us. So that as the emergency response is redesigning the HIV program, there is heavy presence of the recipient of care voice in that conversation. Oui, c'est ça. Thank you.
Thank you, Maureen. So to the three of you, half a minute each in response. We'll start with you, Dio.
Thank you very much, Maureen, and congratulations for the interim. Yes, in regard with sustainability, in terms of community engagement and scorecard, as we have seen that we, the driving of change, we don't need to lose the momentum. At any point now, we are trying to engage with the Rwanda Biomedical Center to see whatever the intervention that are designing should be really focusing on the community interventions than for the sustainability approach, because we know we hold up the burden on our shoulders, and we know we are the expert of the response. Then, with that aspect, we think that we need to keep the approach that has been worked, that we have seen it working, and we believe that it will always work. That's why we think keeping improving and expansion and adapting towards the sustainability approach as a big roadmap to the community, which is really much better than redirecting again the interventions. That's where we will be not losing much, and containment of the disease, if I may say. We think as a community in the center, nothing for us without us. We need to keep it in that aspect, because we have seen working, and we are sure that maintenance or sustaining the gains without losing a lot. Thank you very much.
Thank you. Let me respond to Angie's request to clarify what Maureen was asking also on the chat. Maureen was asking, to what extent is your organization engaged in the emergency response in DRC? In this case, emergency response, Maureen, I assume, is in view of the current funding crisis, right?
Yes, thank you.
Compre, Ange?
Ouais, j'ai compris.
Okay, so you can go on and just respond, then we'll have Lawrence come in. Ange, you have the floor to respond to that question.
Ok. En fait, ICOPLUS siège dans le panel avec les systèmes des Nations Unies dans le cadre des interventions en situation humanitaire. Le panel est présidé par OCHA, qui est l'Organisation des Nations Unies, sur tout ce qui est action humanitaire. Vous savez que la République démocratique du Congo est un pays avec beaucoup de zones d'insécurité et beaucoup de catastrophes naturelles aussi, ce qui fait que la RDC est en soi un pays avec beaucoup de problèmes humanitaires. Et dans ce cadre-là, avec le système des Nations Unies, coordonné par OCHA, il y a des programmes justement d'intervention en milieu humanitaire pour lesquels, comme vous savez, l'approche communautaire est la mieux adaptée. Et par rapport à cela, dans le cadre de la lutte contre le VIH, UCO+ est au premier plan dans tout ce qui est activité communautaire en milieu humanitaire. Pas très longtemps, nous avions réalisé une enquête pour justement identifier les personnes vivant avec le VIH en situation humanitaire, en situation d'urgence dans les provinces du Nord Kivu, Sud Kivu et Ituri, qui sont en fait les provinces à haute insécurité avec des guerres et donc en situation humanitaire. Nous avons travaillé avec le PAM pour les identifier et aussi de sorte que une prise en charge adéquate leur soit adressée. Voilà ce que je peux dire par rapport aux activités en situation humanitaire. Je vous remercie.
Okay. Thank you. Lawrence, 30 seconds.
Thank you very much, Patrick. Thank you, Maureen, for your question. In terms of the community, we are aware that we have a policy now of integrating HIV into the general health care setting. And as the community, we are now engaging with the Ministry of Health and other stakeholders to ensure that the recipients of care as well as community will now be actively involved in the processes. We see that usually we come at the end, but now we are saying I think it's high time now that we will not be having a lot of resources. There will be need to rely on the community and community structures. So incidentally, we already have guidelines. The ministry has what is called the Community Health Department. We have community nurses, we have health surveillance assistants. Everything is in black and white. What we need to do now is to reactivate ourselves into gear and make sure that the integration agenda is implemented with the involvement of the structures that are already there from the community. Thank you.
Thank you very much, Lawrence. The question I was going to ask, Nelson and Elsie, shall be transferred to the next webinar that we shall talk about, where we'll talk about sustainability. And Pragashne will close for us with that part of the next webinar. But before that, I'd like to invite Maureen to give us your reflections from Sequin and ICAP on what you have seen over the years, the importance of community engagement as far as data collection is concerned, putting together the narrative from data and doing some advocacy work to bring about change. What's Sequin's reflections on that as we have journeyed through this process? A minute or two. Sorry, we've eaten into your time.
No problem. I can shorten my submission into a minute or two. So absolutely, and this is a very fundamental question, and allow me to reflect on these insights on how or the significance of community engagement and its role in enhancing the coverage and quality of HIV care. This is why we keep insisting on sequence coverage and quality of HIV care, especially around advancing differentiated service delivery over the years. I'll start by saying, even with the design of the CEQUI network, we have designed it to be and to have a collaborative framework. So the network is actually built on a partnership with ITPC and the Community Advocacy Network, really to make sure that we have the community voices intentionally being amplified across the different platforms within the network, whether it's the meetings, whether it's the communities of practice, whether it's the webinars, whichever platform that we have. And this collaborative framework has been in place since the beginning of the network in 2017, deliberately so. And currently we have 21 member countries, as you all know, within CEQUI. And through this networking, the design also includes making sure that the network or member countries join the network through their ministries of health, bringing together the ministries of health with their recipients of care organizations, deliberately so. And it's deliberately designed that way to make sure that we keep having that underpinning message that we need the community voices in everything that we do. Then even within the collaborative work we've done and jointly worked in co-creating and deploying various tools and resources, which include the community engagement tools that you've talked about, as well as the recipient of care satisfaction toolkit. The design and co-creation of all these tools and resources were done in a way that we make sure that the community voices are driving the design of the tool so that they are picking up on exactly what the community needs to hear and needs to learn about, and also engages the ministries of health so that that information and even the design of that tool is, there is input from the ministries of health as well. So if we talk about specifically how this community engagement tool has supported the network over the years, it's gone through several iterations and changes over the years. And the couple of iterations it's undergone has just been designed to make it really honed in to what the recipients of care really want to see and really want to hear in terms of how do we turn community engagement into numbers that we can track over time and see improvement over time. So that tool actually comes equipped with a comprehensive set of indicators that assist ministries of health, therefore, to have a structured approach to even understanding how well they're engaging the communities that they serve in DSD programming at policy, program, and community levels, which is very important, as we've heard from the case studies today. And that continues to be part of our emphasis, that we need to message or work with the CAN, with ITPC, to see how to message the needs of the community in a language that also the ministries of health can comprehend, can understand, and can engage with, and can foster change over time, and also help the community to track change over time. So that really has been instrumental for us throughout the years. As we move into a different era of HIV programming in 2025, but just allow me to say that it's important, in closing, it's important that even we as a network, we have pivoted to support member countries a lot more in this current emergency response. So as we are shifting into this emergency phase and looking at how the funding for this community work is under threat, then how do we shift this excellent work and best practices that we have around community engagement and really putting numbers to community engagement at all levels, policy implementation and policy subnational levels as well as community levels. How then do we restructure the community engagement agenda to make sure it is aligned to spurring change in this emergency response situation that we are currently in? And how do we continue to sustain the community voice throughout the emergency response that we are currently sort of dropped into in a chaotic way, to make sure that we continue to drive the agenda? The community voice still needs to inform policy right now, as policies are being shifted and changed, and also make sure that works through implementation as well. So just that's my quick submission, summarize a lot of things, but
Yep.
allow me to stop there.
Thank you very much, Maureen, for your reflections. The tail end of your reflections to be able to answer those very questions is actually very spot on, because those questions will hopefully be answered in the next webinar on sustainability, and also during our pre-meeting in the June meeting. So this webinar really, other than showcasing the good work we've done, is actually a preamble on the next two engagements, the next webinar and pre-meeting, to discuss about sustainability and ensuring that this crisis doesn't stifle our intended efforts or erase all the gains that we have had. Sorry, we went overboard by a few minutes because we had to wait for people to come in and the usual logistical issues. So I will end there. I will end there and say thank you very much for the panel, to the panelists, for the inputs you put in preparing for this webinar. Thank you, Pragashni, and Nadia, and everyone else who contributed to making this webinar, including the interpreters. Much appreciated. And so over to you, Pragashni, to end the meeting.
Thank you so much, Bachin, and thank you so much for everybody that stayed. Just listening to everyone, I appreciate, I know everybody appreciates the passion that has remained despite the challenging times that we are faced in. And thank you once again, Maureen. I know it has been a really busy period for the team as well. Thank you for your availability. And with that, I would like to officially close and let you know that we are looking to host the sustainability webinar during the week of the 27th of May. And we will definitely keep in touch. And with that, take care and enjoy the rest of your evening. Thank you so much.